Cancer claims more than 500,000 lives a year. In this special Focus on Health report, PBS 39 investigates the latest tools to prevent and detect one of the United States' leading causes of death. Get advice from the region's leading oncologists on the screenings and tests that could save lives. And hear about a group of patients called Previvors who took active steps to reduce their risks. It's all coming up on this Focus on Health special report.
Focus showcases the people, places, and issues that matter to you.
Everybody has a story.
These are the stories that uplift and inspire right here in your neighborhood. Focus on what matters. You never know what you're going to see when you tune into Focus.
Support for Focus is provided by
Univest, banking, insurance, investments, fellowship community, continuing care with spirit, and by viewers like you. Thank you. Thanks for joining us for this Focus on Health special report. I'm Laura McHugh. 1 in 2 men and 1 in 3 women will develop cancer in their lifetimes. This year, the American Cancer Society reports doctors will diagnose 1.6 million new cases, including more than 80,000 in the state of Pennsylvania. Our first story focuses on the early detection of lung cancer, by far the leading cause of cancer deaths for both men and women. For more, let's hear from Focus reporter Brittany Garzillo. Brittany?
Thanks, Laura. The American Cancer Society estimates that there will be more than 221,000 new cases of lung cancer this year. For women, the risk of developing lung cancer is about 1 in 16. For men, 1 in 13. And for smokers, the risk is even higher. At Lehigh Valley Health Network, doctors use technology for early detection, and those screenings are now covered by Medicare. 75-year-old Thomas Griffin from South Whitehall Township started smoking at 14 years old.
It was just everybody smoked, you know.
He smoked a pack a day for 58 years, hundreds of thousands of cigarettes in his lifetime. About 4 years ago, he quit with the help of nicotine pills and some motivation.
At the time, we were going on vacation. My wife and I were married 45 years. And I said, you know what? I'm going to make it to the 50th.
Though he kicked his habit, doctors said decades of smoking left Thomas at risk for lung cancer, the leading cancer killer in the United States for both men and women.
There are going to be over 185,000 lung cancer diagnoses made in the coming year. And only about 15% of those patients are going to be alive at 5 years. So we're seeing over 160,000 deaths from lung cancer every year.
According to the American Cancer Society, each year more people die of lung cancer than of colon, breast, and prostate cancers combined.
Smoking is the most common cause of lung cancer. 85% of lung cancer is associated with smoking.
Dr. Elliot Friedman, Chief of Hematology Oncology at Lehigh Valley Health Network, says other risk factors include exposure to asbestos, exposure to radon, and genetic factors.
It's a difficult cancer to treat. It's oftentimes found, most oftentimes found in the very advanced stages. And once you find cancer in the advanced stages, you can control it, but you can't cure it.
Based on Thomas's smoking history, in 2013, his primary doctor recommended he be screened for lung cancer using a low-dose computed tomography scan, also known as a low-dose CT scan.
At Lehigh Valley Health Network, we've adapted low-dose CT screening. Low-dose CT screening means that we're using a very low dose of radiation, no contrast material, a test that takes about 30 seconds to administer, to pick up lung cancer nodules or lung nodules that may represent lung cancer at its very earliest stage.
The CAT scan is very helpful as a screening tool. The problem with lung cancer is when you have an early lung cancer, we don't know about it. Patients very often do not have any symptoms. So this is the only way to find cancers early.
In Thomas's case, the scan revealed a small nodule in his lung.
In this image, it's as if the patient is looking right at us. and you can see the small lung nodule here in the top of his right lung. We were concerned about his lung nodule, and we ultimately ordered a PET scan. A PET scan is a test designed to look for cancer. It's a good test, it's not perfect, but in Thomas's case, the nodule lit up on the PET scan, which increased our concern that this might be something worrisome, that it might be a cancer.
In January of 2014, Thomas had the nodule surgically removed. It was stage 1 cancer.
It was kind of like almost expected after smoking all these years, but I was surprised that it was caught so early.
Dr. Robert Kuklitis, chief of pulmonary medicine at Lehigh Valley Health Network, says that with the surgery, Thomas has about an 85% chance of being cured. Thomas receives follow-up CT scans annually.
That's the whole purpose of lung cancer screen, is finding lung cancers early, because when they're found early, they can be cured surgically.
Medicare will now cover the cost of screening for lung cancer with low-dose CT scans for individuals aged 55 to 77 years old who are either current smokers or have quit within the last 15 years, have a history of smoking of at least 30 pack years, and no signs or symptoms of lung cancer. Dr. Friedman says the actual billing process remains a work in progress, but has a clear message for managing your risk factors.
Don't smoke. If you're smoking, stop today.
Though Thomas will live with a lung disease for the rest of his life and needs follow-up CT scans for the next 5 years, his message to others about early screenings may help save lives.
Don't be afraid of it. It doesn't hurt. It could save your life.
For Focus, I'm Brittany Garzillo reporting.
Thanks, Brittany. To learn more about the tests and screenings that can prevent other forms of cancer, Dr. Israel Ziegelboim joins me now. He's a gynecological oncologist with St. Luke's University Health Network. Thank you for joining us today.
Thank you for having me.
So let me start with a very broad question. Are some cancers preventable?
Many cancers are preventable, and the question is, how do you think of prevention? So prevention can be delivered by screening certain types of signs or symptoms, or by questionnaire, asking people, do you have a new discomfort? Do you have abnormal bleeding? Do you have something out of the ordinary? It can be screened by tests, for example, the pap smear, with or without the use of HPV screening for cervical cancer that nowadays we understand as a highly preventable disease caused by a virus for which we even have a vaccine. So you can vaccinate against the disease, which prevents it, or you can also screen, and you should also screen along with the vaccination to prevent it even further. And nowadays we think of risk reduction and prevention at a whole different level, which is people that have not had any cancer yet, or even a precancer, but have the genetic predisposition to have a higher risk of developing certain types of cancer. And that's a very unique opportunity for us as oncologists, because most of the prevention that I talked to you before, the vaccinations, the screening with pap smears, is something that we as oncologists don't do. That's the realm of the primary care physicians or the family practitioners or OBGYNs. And now we have the opportunity to screen our cancer patients, people that have had certain cancers, and ask them about their family history and identify among their family members who could be at risk of developing certain cancers before they even happen.
And so what next steps would they take if as you're identifying them?
That's a great question, and that's part of we as physicians and our genetic counselor colleagues do. There is always the concern of, is that going to be useful information? So people are always afraid of learning about having a risk that you can do nothing about. So how will it help me to know about this? Well, nowadays we have a lot of interventions that can decrease or almost eliminate the risk for many of those cancers, either by earlier screening with very non-invasive means, ultrasound technology, blood tests, and the like, with all their limitations. Also the use of medications that can decrease risk in certain individuals with certain types of predisposition, and ultimately surgery. We can remove organs at risk before they are affected, and almost cutting down completely the risk of developing cancer or precancer in those patients.
And of course, you're a gynecological oncologist, so which are the cancers that have these opportunities for you to reduce risks in that way?
So for genetic predisposition in gynecologic cancer, the two cancers that we think of the most are cancer of the uterus, specifically the inner lining of the uterus called endometrial cancer, and cancer of the ovaries as well.
And you said that you're screening for two of the larger ones. One is called BRCA, and that's a fairly common one. People know a lot about that one, but there's another very common genetic predisposition that you're screening for as well?
Yeah, so there are many cancer susceptibility syndromes, and many of them, more than the two that you touch on, the BRCA or hereditary breast and ovarian cancer syndrome, and the Lynch syndrome, that it's a one that we also tend to think a lot in our field. There are many more, and many of the others also involve an increased risk of cancer of the ovaries or uterus in some other ways. But by far the most common ones we see in practice, and the ones that affect the population the most, are the BRCA, that increases the risk of many cancers, but especially in the female, cancer of the breast and cancer of the ovaries, as well as many others, as I said before. It has also been associated with cancer of the pancreas, with melanomas, with certain types of brain cancers, etc., prostate cancer in the male, and the Lynch syndrome, which has been associated mostly with cancer of the colon, but also in the female with a very high, almost as high a risk as the risk they have for colon cancer of developing cancer of the uterus, a lower risk but certainly present of developing ovarian cancer, as well as risk of many other fairly uncommon cancers of the small intestines, stomach, gallbladder, and biliary tree and urinary tract. So when we identify these individuals, we're really cutting down in much more than the risk of them developing some of the cancers we treat, because by knowing they have it, they could have completely different screening methodologies for gastrointestinal disease. For example, their colonoscopies are done much more frequently. They develop the need to have screening of the upper gastrointestinal tract with upper endoscopies and the like. So there are multiple interventions that come once and after you have identified these individuals to be at risk.
And I wanted to ask you specifically about ovarian cancer and patient outcomes as a result of these screenings. Are they improving?
They are indeed. So the problem with ovarian cancer is that the vast majority of our patients present with advanced disease, with stage 3 or stage 4 disease. And under those circumstances, even though we have a very good chance of making the disease go away, at least temporarily, by the institution of very aggressive surgical therapy and chemotherapy, the problem is that many of those patients, in some series up to 50%, can have recurrences later. That is opposed to patients we identify with early ovarian cancer, or even further, patients that we treat and remove their ovaries or introduce risk reduction strategies before they even develop the cancer. Patients with stage 1 ovarian cancer have a survival that is in excess of 85 to 90% at 5 years, which is much greater, obviously, and much better than the outcome we have for patients with advanced disease. The problem is that we don't have a screening methodology for the general population, so we're unable to identify individuals with stage 1 disease, and that's when all of this getting smart about family history and genetic predisposition comes into play. If we can act before the cancer even strikes, we're really ahead of the game.
And we'll be speaking with a genetic counselor later in the show. Thank you so much for joining us.
Thank you for the opportunity.
Our next story focuses on the detection and prevention of skin cancers, by far the most common types of cancer. For more, here's Focus reporter Grover Silcox.
Thank you, Laura. According to the National Cancer Institute, more than 76,000 Americans suffered from melanoma of the skin in 2014. More than 9,700 people died from it last year. Still, the 5-year survival rate is 91.3%. I spoke with a melanoma specialist at St. Luke's University Health Network for advice on detection and prevention of skin cancer as we look forward to warmer weather and more time in the sun, a potential risk factor for getting skin cancer.
As winter melts into spring, folks eagerly anticipate spending more time outside.
Obviously, this is the time of year when we start thinking about the sun.
And the time when physicians warn us about the risks of skin cancer, from overexposure to the sun's ultraviolet rays.
More than 1 million Americans per year get skin cancer.
It's the leading form of cancer as a whole. The two most common types are basal cell and squamous cell.
The basal cell cancers, squamous cell carcinomas, they tend to be mostly in the sun-exposed areas, almost always in the sun-exposed areas. So you're talking about the face, the forehead, the neck, very benign. Usually you remove it and you can forget about it.
The other cancer is melanoma. It's the least common of the skin cancers.
It affects about 90,000 Americans per year, and it is the most dangerous one. Once a melanoma is diagnosed, it's not just cut it out and forget it. There's a lot of other steps that need to follow that.
Melanoma can appear in both sun-exposed areas and areas untouched by the sun.
Melanoma can develop in anybody, anywhere.
Dr. Sanjeev Agarwala, a melanoma specialist at St. Luke's University Health Network, treats melanoma patients, including those with metastatic melanoma, which has spread to other parts of the body.
In melanoma, we use drugs that boost the immune system and fight the melanoma in new ways that have very recently been discovered and have been quite successful, or target a mutation that may or may not be present in the melanoma.
Detecting skin cancer in its early stage generally leads to better outcomes. This is why physicians advise patients to regularly check moles and lesions on their bodies.
Its shape, size, color, overall appearance, and change is what you look for.
Dr. Agarwala recommends the ABCDE method for checking symptoms.
A for asymmetry, so if a mole is symmetric, 2 equal halves, that's good. Asymmetric, not so good. B is the border. If it's irregular, not so good. C for color, 1 color, good, multiple colors, not good. D for diameter, which is basically size. More than a pencil eraser head, about 5 millimeters, is something that we look as something might be important. However, size is not always important. And E for evolution, which is like change.
Some people have higher risk for skin cancer.
So the people who are more prone to getting skin cancer are those that have very light skin that tends to burn easily. Hair color seems to be important. Red-headed people have a higher incidence, light-colored hair, blonde. Having a family history.
And yet, even people who don't have risk factors can get skin cancer.
The highest risk for melanoma development in later life occurs in childhood. So if you get a melanoma at 50, it's probably something that might have happened to you when you were 10 or 15. So you really want to protect your kids.
And yourself. By applying sunscreen of at least SPF 30 every 2 hours when in the sun, by wearing protective clothing and avoiding tanning booths. You also want to check for unusual-looking moles and get your skin examined by a doctor at least once a year.
I do want to emphasize the sun is not your enemy. The sun is our friend. You shouldn't say that I'm not going to go in the sun at all because it can cause melanoma. That's not what we're saying. We're saying that enjoy the sun. Just know your risk and take precautions.
And if you have any risk factors or symptoms, consult a doctor. Remember, early detection is key. For Focus, I'm Grover Silcox reporting.
Thank you, Grover. To learn more about how each of us can assess our own cancer risks, I'm joined by certified and licensed genetic counselor Andrea Smith of St. Luke's University Health Network. Andrea, thank you for joining us today.
Thank you for having me.
As we were talking about earlier in the show, sometimes it's more information than you want. So who should seek a genetic counselor?
So certainly anyone who has a strong family history where we're seeing multiple family members with the same or similar types of cancer, individuals in the family who are diagnosed at a young age. So for many cancers, think of things like breast cancer and colon cancer, diagnosed under 50. Also, if there are people in the family who've had more than one cancer, so more than one separate cancer. So thinking of, for example, the BRCA genes, women with both breast and ovarian cancer, for example, can be a red flag. Even certain ethnic groups are at a higher risk. For example, someone who comes from an Ashkenazi Jewish background may have a higher risk of having a genetic predisposition to certain cancers.
And we're talking in this episode specifically about cancer, but you can find out with a genetic counselor your risk for a whole number of diseases and other conditions, can you?
Certainly. Genetics is becoming a big part of a lot of different areas of medicine. As one of the biggest areas of genetic counseling is working with individuals who are going through a pregnancy or planning a pregnancy to see is there anything running through the family that could potentially affect their future offspring. Pediatrics, neurogenetics, so looking at things like Huntington's disease, Parkinson's disease. There are cardiac conditions that we can see higher risk for with certain genetic components. So it's really something that if you see it running through the family in a very strong pattern, there could be genetic testing there that would help us understand risks.
So how does it actually work? What does the test entail?
So most genetic testing is pretty straightforward, usually a blood sample, or some can be even done on a saliva sample. So simply spitting into a tube, they can pull DNA from cheek cells, or in the case of a blood draw, they can pull it from blood cells. and use the DNA to look at certain genes to see are there changes or errors in the gene that could lead to a higher risk of certain conditions.
Do most people want that information?
I think it depends on what information we're looking for. When we think about cancer, it can really help us take preventative type steps. For other conditions, things maybe like Huntington's disease, we don't really have as much as that we can do right now, though some people do like that information for planning purposes. It helps them plan for their future care, plan for their families. And I think genetics is becoming a much larger piece of people's lives. I think for a long time, genetics was a little scary, it was a little frightening. And there was a lot of worries that, could genetic information be used against someone? Could they lose their job? Could they lose their health insurance? We have protections there now. Also now that we do have options, so whether it's extra screening, lifestyle management, things that we can do with this information to really help either prevent or lower risks.
You mentioned, for example, health insurance. Is insurance regularly covering genetic counseling now?
Oftentimes, if there's a family history or a personal history that's suggestive of a cancer syndrome or other hereditary disorder, then very often genetic testing is covered. I find that if I have a patient in front of me and I feel that genetic testing is something that would be helpful for them, usually the insurance does cover it.
And for somebody who does know that they have a family history and are considering genetic counseling or genetic testing, at what age should they start considering it?
For many conditions, if it's something that isn't going to affect the individual until after adulthood, we say 18. If there are interventions that we would take prior to that, so in some cases, if it would be something we would start some screening in childhood, we can do genetic testing earlier. But for many, especially the cancer conditions, we recommend starting at 18. Then that individual can make the decision for themselves as an adult whether or not that's information they want to know.
Is the demand for genetic counseling growing, and if so, by how much?
Oh, certainly. It's a field that's growing very rapidly as we're understanding more and more about genetics. The technology behind genetic testing has evolved very rapidly, so now instead of testing one gene, we can test for many genes at a time. So it's something that's growing in all fields, from cancer to cardiology, neurology, even psychiatry. There are many different areas of genetics that are all just exploding at the moment.
And before we wrap up, what's the number one thing you want viewers at home to understand or to know about genetic counseling?
I think that genetic counseling is really a process of understanding what the information can tell you, understanding your family history. I look at it almost like a teaching process where even if you have any questions, you can come in, meet with a genetic counselor, learn the information. Doesn't necessarily mean you have to have genetic testing, but it's a way to get the information to really make an informed decision.
All right, Andrea, thank you very much. Well, we'd love to hear how you've taken steps to prevent cancer. Join us on social media at PBS 39 on Facebook and YouTube, and at PBS 39 channel on Twitter. You can also find us online at WLVT.org/focus. We also want to thank our friends from Southern Lehigh High School joining us in the studio today. You can learn more about our Focus Field Trip series by emailing us at focus@WLVT.org. And it's no coincidence that we decided to focus on cancer this week as PBS 39 has been airing the Ken Burns Cancer Series.
Right. And I think what's interesting is that you find so many of the doctors, researchers, scientists are so excited about the prospects now, fighting cancer with new therapies, new treatments, new developments like never before.
In fact, Dr. Zigerboim was telling me that the HPV vaccine is now recommended for both boys and girls. Starting at age 9, available starting at age 9.
That's right. And with me, doctors really stressed that early detection is key, especially in terms of lung cancer. We're hearing about cancer pre-vivors, so it's really key.
Right. Obviously the same with skin cancer and probably all cancers.
Grover, Brittany, thank you very much, and thank you for watching. We'll see you next week. Until then, remember to focus on what matters.